Get organized. You answer in a very accurate way, everything. Whatever you speak, if you don't organize your answer, it looks absurd. It doesn't make sense. Somebody said immunosuppression, then he said HIV, then he said sarcoidosis. Then you divide your entire description into some semblance of an order. Inflammatory, malignant, and non-specific in the miscellaneous groups. Inflammatory causes acute inflammations, chronic inflammation. Chronic inflammation, tuberculosis. Acute can be tuberculosis as well as syphilis. Nobody is asking you to say primary or secondary because it is no longer seen as a disease anymore. It is more or less disappeared. So basically inflammatory, malignant and other causes. The other causes include basically disorders which involve the lymph nodes themselves. So there will be further division. A lymphadenopathy could be primary or secondary. The primary is happening due to diseases that involve the lymph nodes themselves. And secondary happens due to some disease elsewhere which metastasizes or causes involvement of the lymph nodes. So it is as simple as that. And now everything falls into place. You can have all those conditions that you were describing divided automatically. And when you are presenting a history, exclude those conditions in your history, especially the malignant condition. Now let's look at just the lymph node as an organ, lymphatic system getting affected. The most common cause is there are diseases involving the lymphatic system, inflammatory and malignant. Inflammatory, I've just discussed. One is tuberculosis, syphilis is not so common, infectious mononucleosis, etc. Now, lymphoma can be primary lymphoma, which can be non-Hodgkin's, Hodgkin's lymphoma. Therefore, your examination should have involved examination of the abdomen. I'm telling you what all is missing. Because generalized lymphadenopathy could be due to lymphoma, where you need to examine the abdomen. If you treat this patient in the case of generalized lymphadenopathy, your job is easier. Is that clear? And even if you're saying tuberculosis, you need to examine the other lymph node regions which you have examined, but you did not describe. Which would mean cervical, inguinal, popliteal, etc. Clear? There are certain malignancies which also produce disseminated lymphadenopathy, which are not malignancies of the lymphatic system. Breast, like if the patient had carcinoma breast, there could be lymph node involvement of the axillary, supraclavicular fossa, that means both sides. So exclude that. So there are primary causes, secondary causes, which could both be divided into inflammatory, malignant. And then you have miscellaneous causes, which are related to certain metabolic disorders. Then HIV, somebody mentioned. HIV per se, or HIV leading to tuberculosis becoming rampant, or tuberculosis becoming subclinical, tuberculosis becoming clinical. So HIV per se can also produce lymphadenopathy or malignancies. Which malignancies you get with HIV? Kaposi sarcoma. So, you can get Kaposi sarcomas. They are associated with lymph node involvement. So there can be causes which are beyond your thinking. You're only thinking about that little area. That is why there was a confusion. I'm just trying to expand it into a generalized lymphadenopathy so that you, next time when you get a case like this, you are able to discuss it as a generalized lymphadenopathy. And I'm not interested in the tubercular part of it, which is what you are interested in. That looks like the shortest approach to it, which is not correct. Bilateral lymph node involvement is not common in tuberculosis unless it is disseminated. And if it is disseminated, you need to exclude MDR or HIV underlying immunosuppression. It's not common to get just axillary getting involved. In this patient, therefore, examination of the chest was important, lungs were important, abdomen was important. It becomes a big case, and it becomes a case of generalized lymphadenopathy is a long case, not a short case. The same can double up as a short case. Okay, just examine the right axilla. That's a different story. So if you're going for USMLE or you're going for PLAB or whatever, they'll say, okay, just examine the right axilla. Don't tell us, I'm not going to CS examine. They'll just ask you to examine the axilla. Don't bother about the entire thing. That's a different ballgame. Here, it's a case. And in a case, you need to find out what is the reason for what you're talking. And therefore, have a broader picture rather than a narrower one. This became a narrower picture. That's why a case presented was over in 5 minutes. If there was nothing else you spoke about. Then there are conditions which are beyond tuberculosis. Lymphadenitis suppurativa, which has nothing to do with tuberculosis. That also produces lymphadenopathy. That can be bilateral. What is lymphadenitis suppurativa? You don't know? You answer? You saw the case.
Yes, sir.
Yes, what is it?
Formation, infection or inflammation of the lymph nodes resulting into.
Where does this patient go? Surgery or dermatology?
So initially, the patient goes to dermatology.
Why?
So because what happens, the hair roots or the apocrine sweat glands get infected. Most commonly due to Staph aureus,
Staph aureus, and it's a skin infection which drains into the lymph nodes, and then it happens in sweaty people with lots of hair in the axillae. They tend to sweat a lot, and these ducts keep getting blocked. It keeps getting infected, keeps getting inflamed. The lymph nodes keep getting enlarged. So it's a regular phenomenon that is happening. Very commonly seen in women with obesity also. Then it becomes a disease which involves the lymph nodes. And when lymph nodes get involved, they coalesce all the joint. Inflamed lymph nodes mat the joint, coalesce and form an abscess. Lymphadenitis suppurativa. Then that comes out as a pus. Suppuration means formation of or throwing of pus. That is lymphadenitis suppurativa. That also is a differential diagnosis. Therefore, make your tuberculosis stronger and make it into a generalized lymphadenopathy, then that excludes lymphadenitis suppurativa. If this was only in the axillary, it would be one of the differential diagnoses.
Yes,
because isolated axillary lymph node tuberculosis is not common. I mean, you don't reach axilla there directly, it has to come via somewhere. So then you have to find out where the source is. Therefore, it's important. Therefore, the description of skin is important. Do you get my point?
Yes, sir.
That is why I was trying to change your outlook. You should look at it differently. Had you looked at it differently, you would have approached it differently. You move on to the differential diagnosis. We have got certain inflammatory conditions and certain malignant conditions. Malignant conditions could be primarily of the lymph nodes, or they could be metastasis to the lymph nodes. I think I have covered that. I am not going to discuss it. Primarily would be lymphomas. Inflammatory tuberculosis, infectious mononucleosis, sarcoidosis. Clear? The secondary could be coming from the breast, coming from the lungs. It could be tuberculosis, the lung which goes there, malignancy of the lung also goes there, the axilla. And therefore, why did I ask you to describe the arm? Where does the arm drain? Into the axilla. Sometimes there are diseases of the hands. Repeated infections do happen in the hands also, in the fingers, along the skin anyway. So it's very simple. The moment you make a spider diagram about, okay, this is generalized lymphadenopathy, and lymphadenopathy can happen due to only 3 causes: inflammation, malignancy, or non-specific. Non-specific is where you don't know the cause. It can come from anywhere. Commonly tuberculosis, less commonly malignancy. Malignancy could be primary, which is a lymphoma, or metastatic from anywhere. And that's it. You can defend either way. Points in history, points on examination. Points in history, chronic history, long history. You're right. History of sinuses, common. Why is it common? We'll just come to that. And history of constitutional symptoms, and more importantly, history of receiving ATT, and even more importantly, we get default. When he gets tuberculosis now, it's not a good one. Malignant. Lymph nodes are, no, there's no point in history to suggest it. No other, except for the cervical, no other lymph nodes are involved. They are firm in consistency, they are matted. So every point becomes important there for an examination. by history and by characteristics of the lymph nodes, you can differentiate. So it is a case of tuberculosis, which is involvement, which is produced generalized lymphadenopathy. Don't say tuberculosis with axillary inflammation, it's generalized. Clear?
Yes, sir.
When does tuberculosis produce generalized lymphadenopathy? In immunosuppressed individuals. So what else you would like to know? The status. How do you proceed? Again, you'll get up, somebody will say X-ray, somebody will say. I've taught you how to answer that question. How do you investigate?
Investigations to confirm the diagnosis, to support the diagnosis, to stage the disease, and to
Treat. Good. Now, what do you do to confirm? No more applause. This is not enough. He was hoping. They were all hoping to do it, right? This needs to be answered now.
blood.
So now what do you do to confirm the diagnosis? You're right, to confirm the diagnosis, to support the diagnosis, and this is not malignancy, to no staging, and to treat. So what would you do to confirm the diagnosis, sir?
Regular investigations to confirm and blood examination.
Okay. I didn't hear you. Be very, very, they say Lima Charlie, loud and clear. Be Lima and Charlie. Don't speak into your own mouth. Who will hear that? Speak now. From where? You're right. From where? From the lymph node. This swelling would be pus, no?
Yes, sir.
That won't help. You can aspirate the pus also and send it for
Culture and
tubercular culture, which is in the.
microbiology.
How long does it take? It's reduced now. Okay.
CB NAT, which gets in
So,
2 days.
who else? Last row. Investigation to confirm the diagnosis. Would you agree with what he's saying or you differ? He said FNAC. Well, you have lymph nodes in the cervical region also. And radiological investigation will come handy.
Ultrasonography.
X-ray chest, FNAC from the lymph node in the axilla as well as in the neck. Preferably after putting the patient on antibiotics. So there's commensals and secondary infection is reduced. You can do ultrasound of the, please sit down, ultrasound of the axilla if you like, not needed. If this was a suspicion of breast malignancy, ultrasound of the breast will be done. Not here, it's a straightforward case. And then routine, complete blood count and other investigations to treat. That's about it. Now what do you do to treat it?
We start the patient after getting the culture done.
What category would this be?
Category 2. Category 2 patients. So in this patient, we will start the patient on a category 2 regimen, which is HRZES 5.
How would it matter if you, you're asking for the HIV status? Why do you want to know that?
So HIV status will also affect the infection because they will be superseded opportunistic infection.
So what do? You found out he's positive.
So we will not only start with these, we will also start with other antibiotics to prevent opportunistic infections. It's also start with antiretroviral drugs. ART, antiretroviral therapy.
So start with ATT, then ART.
Then ART.
And yes, 2 to 3 weeks. And if the patient has got abscess, it needs to be aspirated. What is collar stud abscess?
From the deep fascia, the separation
It goes through the deep fascia and comes to lie under the superficial fascia. So there is a collar stud. See that collar stud?
That's a deep cynical.
Skin, deep fascia. This is collar stud. See that stud in the collar, especially in with the bow it comes, and otherwise some shirts also have that collar stud, wide base buttons.
Yes, sir.
So collar stud abscess is in the neck. It is seen in tuberculosis commonly, but it can be seen anywhere. In axilla also you can get it. But this is acute suppuration. So it's an acute or chronic abscess. Acute abscess is suppurating. So local signs of inflammation are present. Cold abscess will not have local signs of inflammation. So you need to take care of the systemic part by starting the patient on anti-tubercular treatment and ART if needed. Secondly, draining the pus. How do you drain this pus? What is special or typical of drainage of a tubercular abscess? Very good. Give a big round of applause. Now, I know you take a while. Why anti-gravity? Otherwise we'll applaud backwards now. Or lose it all? Yes. Yes. Looking at all the tigers. Yes. Anybody?
So it can lead to sinus formation.
Yes, give him a big round of applause. This one is more important. Never ever drain a tubercular abscess with gravity. You will have a persistent sinus. It doesn't heal, so you must do anti-gravity aspiration. Now when you do anti-gravity aspiration, you will have pus for culture sensitivity. You will send it for the tubercular assessment, and you'll also meanwhile be aspirating out a toxic element which will reduce the constitutional symptoms to some degree. And rest is anti-tubercular treatment. If the same patient had, don't be surprised, tuberculosis can mimic almost anything. It's a great, mimic. They say tuberculosis can mimic everything, including pregnancy in this part of the world. Pseudocysis with amenorrhea, and the woman continues to think she's pregnant. There is ascites, there is amenorrhea. Right? So, tuberculosis can be covering up lymphomas. We have published our series of tubercular lymph nodes in breast cancer. And out of 10, 3 nodes were positive for cancer, 7 for tuberculosis. You can actually miss out. The masquerader can actually miss out. So, exclude malignancy. Therefore, FNAC is important. When you're doing FNAC, imaging is important. And when you're treating for tuberculosis, assessment of the patient is also important. Don't just think. Abdominal examination was done to look for spleen, which is in Hodgkin's lymphoma, that you have splenomegaly along with lymph node enlargement. Exclude these conditions by careful examination. So that's a case of generalized lymphadenopathy. It's not a case of sinus. It's a common mistake. The moment patient has lymph nodes in the axilla as well as in the neck, you're already dealing with a disseminated case or a case of generalized lymphadenopathy and treat it as such. You'll automatically find answers are there and you don't have a problem. Now, there are questions as to how a collar stud abscess forms. You've covered that. There are questions as to what do you do to a resistant tuberculosis. Read about that. When do you use steroids in tuberculosis? Read about that. In a patient with HIV, treat tuberculosis first, then ART treatment. And finally, remember, these patients also are vulnerable for some cancers that you miss out. So don't miss out. Your examination should be therefore thorough. My whole purpose of taking, you presented, I don't know what you were presenting. I thought you were presenting right leg fossa lump.
Yes, sir. That
You
was,
see that?
the patient is still not here for the admission.
In the ward, if you want, you can see. I think she was asking. The soft tissue
take
sample
it
will be
today.
operated tomorrow. The other one you could have seen. But anyway, this is a good case. I was just coming that you're coming to the point that you picked up a good case, which is the case of generalized lymphadenopathy, rarely discussed. If there are any quick questions, you can ask me. My idea of this class is so you understand Don't approach it with a narrow vision. You're likely to miss things. If you had looked at it as a generalized lymphadenopathy, I'm sure you would have asked these questions. So it is not that this case will come in your exam, but this kind of a case will come in your exam. Have a generalized approach. Don't be so focal and narrow that you miss out. If you examine the axilla completely, I'm repeating what I've said already. Examine the axilla, don't examine those sinuses. And what do you mean by examining the axilla? The same that you do in the breast case. Examine all the lymph nodes. Describe their consistency, describe their mobility, describe their number, describe their anatomical position. And don't miss to examine the other lymph nodes, which you do in any case with lymph node enlargement. Then it becomes a very simple case, there's no problem there. Narrow opening in a broad base, classical of tuberculosis, multiple sinuses joining, forming a hardened, like you have in the neck. You can have a, as they call it, the collar around the neck, they call it. This is the same thing that happened. What is the other name for collar stud abscess? Last row. No, you have to stand up and say no. You'll get some fresh air. You, sir. Next. Next row. It's given in your book. That's what I'm asking. It is related to a king. It's called king's evil. What is the meaning of that? Generally the more aware kind, so I thought you will answer. No? Please, Ayushi. You know, this was in 1920s.
With the king's touch.
People thought who had such swellings, they thought if they would go to the king, they would heal.
Whoever he touched,
Good.
the patient
It was
will-
considered that if the king touches them, they don't go touch. With the touch of the king, who was considered God in England not long ago, don't think they were a very advanced world only 40, 50 years ago, 60 years ago. There was no voting for women in England till 1950. Very advanced country. Now, so king would touch them and they will become alright. So what did the king do? He talked to his prime minister and said, obviously this is not true. Because I don't think I can heal anybody. But their belief is strong, so what do? Those days we didn't have anti-tubercular treatment. The treatment for tuberculosis was sending these people to sanatoriums. Pandit Nehru's wife, Kamala Nehru, spent 1 year in sanatorium in Switzerland. And she died there. People were isolated. Tuberculosis was treated like you will die. So he will touch everybody. And they were impoverished because there was nothing to eat. There was a famine also. So England was in trouble. He would touch everybody and give 1 guinea. So that there will be some food to eat. So miraculously, some people started getting all right. It's because they started eating. And when they were getting well, it's called king's evil. So he touches and they get well. The other name is scrofula. So scrofula, king's evil, and collar stud abscess, they all mean the same thing. It happens because it's a slightly less acute inflammation. Understand the process. Leprosy is even slower. So it does produce inflammation, and there is something called a cell-mediated immunity you're taught in pathology. It will happen slowly. Fibrosis would happen. The tubercle would form over a period of time. Langerhans giant cells, caseation, lymphocytes, fibrous tissue, and a tubercle is ready. And then it forms what is called Gone's focus. What is a primary complex? Basic MBBS question. Give me a complete answer. This is a basic question. It is Gone's focus, lymphangitis, and lymphadenitis. 3 parts. Focus, lymphatics, node. Please sit down. So there is a primary complex, which is what it starts with, which heals, and it flares up in an immunocompromised individual. Even on BCG inoculation, there is a primary complex involved. Sometimes you can have a node in the axilla if you give BCG to somebody there. So well, that is the treatment. And you rarely will have acute suppuration, which will need drainage. And when you drain, you know that you have to do anti-gravity drainage. Okay?